This is the third lecture for GI physiology. The secretory glands of the gastrointestinal tract serve two primary functions. First, they provide digestive enzymes. Second, they secrete mucus for lubrication and protection of all parts of the gastrointestinal tract. Today, we will cover 7 topics. First, I will give you a brief introduction to secretion. Here's a table that provides the amount of secretion each secretory gland normally secretes each day and the pH. This table shows small intestine has the most secretion, followed by stomach. There are 2 types of secretions. One is serous secretion. The other one is a mucus secretion. Serous secretion is a watery secretion that contains enzymes. They are directly involved in digestion. Mucus secretion contains water, electrolytes, and glycoproteins, including mucin. It is also essential for digestion because mucus is adherent. It sticks to food. Mucus has sufficient mass that it coats the wall of the gut and prevents actual contact of most food particles with the mucosa. Mucus has a low resistance for slippage, so the particles can slide along the epithelium with great ease. Mucus causes fecal particles to adhere to one another to form feces. Mucus is strongly resistant to digestion by enzyme. Mucus contains the glycoproteins that have a buffering capacity. There are several types of secretory glands. First is single-cell mucus glands. They are also called mucus cells or goblet cells. They are typically found on the surface of the epithelium. Second is tubular glands. Tubular glands retain their shape as a tube throughout their length. Examples include Brunner's gland, crypts of Lippert, and oxyntic glands. Third is complex glands. Salivary glands, pancreas, and liver are complex glands. These glands lie outside of the wall of the GI tract. Secretion is controlled by several means. Direct contact of food is sufficient to stimulate the mucus cells to secrete mucus. Tactile stimulation, distension of the gut wall, and chemical stimuli activate the enteric nervous system. The resulting nervous reflexes stimulate both mucus cells and tubular glands to increase their secretion. In the stomach and in the intestine, several different hormones control the volume and character of the secretion. Parasympathetic stimulation increases glandular secretion rate. Sympathetic stimulation has a dual effect. Sympathetic stimulation alone usually slightly increases secretion, but sympathetic stimulation also constricts the blood vessels and reduces the glandular secretion. Now, let's move to part 2. We will look at secretion of saliva. Saliva contains a serous secretion and a mucus secretion. Serous secretion contains alpha amylase or ptyalin. Mucus secretion contains mucin. The principal glands of salivation are the parotid, submandibular, and sublingual glands. Especially, secretion from pyloric and submandibular glands constitute 90% of saliva. Salivary secretion is a two-stage process. First stage involves acini. Second stage involves the salivary ducts. Acini secrete primary secretion that contains alpha amylase and or mucin in a solution with concentration similar to that in plasma. As the primary secretion flows through the salivary ducts, the ionic composition of the fluid in the saliva is markedly modified. Here is the acinius. The glandular cells secrete a primary secretion that is nearly isotonic. When we zoom in, we see two key players. One is sodium-potassium 2-chloride symporter that brings in chloride. The other one is a sodium proton antiporter that removes proton. Chloride and bicarbonate leave the cell through an anion channel located in the apical membranes of the acina cell. This secretion of anions drives entries of sodium and water into the acina lumen across the relatively leaky tight junction. Acina cell fluid secretion is enhanced by a rise in the intracellular calcium level. In ductular cells, the situation changes. The presence of three parallel antiporters, as shown here, three antiporters, resulting absorption of sodium and chloride from the lumen and secretion of potassium and bicarbonate into the lumen. As a result, under resting conditions, the concentration of sodium and chloride in the saliva are only 1/7 to 1/10 their concentration in plasma. Conversely, concentration of potassium is 7 times as great as in plasma, and concentration of bicarbonate is around 3 times of plasma. Saliva is hypotonic. Here we have two charts. The first chart shows normal plasma values of iron concentration. The second chart shows change in iron concentration in saliva in response to an increase in flow rate. As the flow rate increases, the concentration of most ions approach plasma value except bicarbonate. Bicarbonate concentration remains high because salivary agonists stimulate specifically its secretion. Saliva is always hypotonic, but its osmolarity increases as flow rate increases. Saliva contains a mucus, therefore it has lubricating and protective properties. Saliva also contains serous secretion, therefore it initiates starch digestion and solubilizes dry food. Finally, saliva plays an important role in oral hygiene in two major aspects. One is that it helps wash away bacteria. The other one is that it contains several factors that can destroy bacteria. These include enzymes, most notably lysozyme, chemicals such as thiocyanate, and antibodies. Control of salivary secretion is exclusively neural. For example, when a person smells favorite foods, Nerve signals arrive in the salivary nuclei in medulla. Salivary nuclei send efferent signals through cranial nerve 7 and 9. These fibers form synapses with postganglionic neurons in ganglia in or near the salivary glands. They secrete acetylcholine, which activates the receptor in the salivary glands. Activation of receptor increases secretion of saliva and kallikrein. Kallikrein is a protease. Sympathetic nerves from superior cervical ganglion also increase salivation to a smaller degree through norepinephrine. And these are the factors that decrease secretion of saliva. This information is summarized in this slide. Here, I want to point out two aspects. One is postganglionic nerves secrete acetylcholine, which activate muscarinic receptor M3. It is a G protein couple receptor. Activation of M3 increases secretion through G-alpha-Q IP3 pathway, which leads to increase in intracellular calcium level. Second aspect is salivary cells also secrete kallikrein, a serine protease that cleaves alpha-2 globulin to form bradykinin. Bradykinin is a potent vasodilator. Here is a clinical correlation. Xerostomia is characterized by dry mouth. It can be caused by use of illegal drugs, insufficient capillary perfusion, radiation-induced damage on gland, or autoimmune disease, among others. Treatment includes the use of parasympathetic mimetics, organic acids, and chewing gums. The opposite condition is drooling. People with this condition have saliva dropping uncontrollably from the mouth. A sudden onset of drooling may be caused by poisoning or reaction to snake or insect venom. Other chemicals can also cause drooling. Treatment may include anticholinergics or surgery. The third condition is too little reabsorption of sodium chloride in ductal cells. This occurs in patients with cystic fibrosis. Concentration of sodium and chloride ions are elevated in saliva. This condition is caused by mutation in CFTR. The opposite condition is primary aldosteronism with excess aldosterone. As a result, concentration of sodium chloride is close to zero and elevated potassium levels in saliva. Now, let's move to part 3. We will look at gastric secretion. The stomach serves as a short-term storage reservoir for food. It secretes intrinsic factor. It initiates digestion of proteins. It liquefies food and slowly releases it into the small intestine for further processing. Gastric secretion is mediated by two types of tubular glands. One is oxyntic gland, and the other one is pyloric gland. Oxyntic glands are located on the inside surface of fundus and body of the stomach. They constitute about 80% of the stomach. Pyloric glands are located in the antral portion of the stomach. They constitute about 20% of stomach. Oxyntic glands secrete hydrochloride, pepsinogen, intrinsic factor, mucus, and renin. Pyloric glands secrete a small amount of pepsinogen, mucus, and gastrin. Gastrin control gastric secretion here. Gastric acid or stomach acid contains hydrochloride, potassium chloride, and sodium chloride. It is bacteriostatic. It converts pepsinogen to pepsin. It begins protein digestion along with pepsin. Pepsinogen is a precursor of pepsin. Pepsin is a protease. Two signals stimulate secretion of pepsinogen. One is vagal stimulation, mediated by acetylcholine. The other one is gastric acid. Intrinsic factor is produced by oxyntic glands. It is essential for absorption of vitamin B12, as we have covered in biochemistry. So here's the integration with biochemistry. Renin, also called chymosin, it is an aspartic endopeptidase. It causes milk to curdle in stomach so that milk is retained in stomach and released more slowly. Here is an oxyntic gland. It is a tubular gland. It is made up of three cell types: mucous neck cells, parietal cells, and peptic cells. Mucous neck cells secrete mucus. Parietal cells secrete hydrochloride and intrinsic factor. Peptic cells secrete pepsinogen and renin. Within each parietal cell, there are small channels called canaliculi. Hydrochloride is formed at the villus-like membrane of the canaliculi and then merged to flow out into the lumen. This is a parietal cell. This is the lumen, this is the apical, and this is the basolateral. The key players for hydrochloride secretion is proton pump. It is a hydrogen-potassium ATPase. It secretes proton into canaliculi in exchange for potassium. Potassium recycles back into the lumen through a potassium channel. Bicarbonate is transported across the basolateral membrane into the extracellular fluid in exchange for chloride. Chloride enters the lumen through an ion channel. Luminosodium enters the cell and is transported across the basolateral membrane in exchange for potassium through sodium-potassium ATPase. Water passed into the canaliculi by osmosis. The end result is high hydrochloride and low sodium chloride concentration, low pH in the gastric acid. In addition, gastric acid is isotonic. This information is summarized in this slide. Here is an effect of secretory rate on ionic composition of gastric juice. When secretory rate is low, for example, in between meals, sodium chloride concentration is high. When secretory rate is high, for example, during meal, hydrochloric acid concentration is high. Pyloric glands are structurally similar to oxyntic glands, but contain few peptic cells and almost no parietal cells. Mucous neck cells secrete mucus and a small amount of pepsinogen. In addition, pyloric glands have G cells that secrete gastrin. Gastric secretion is stimulated by three mechanisms. First, neural mechanism. It works through acetylcholine and increases secretion of hydrochloric acid, mucus, pepsinogen, and gastrin. Second mechanism is paracrine mechanism. It is mediated by histamine. Histamine increases hydrochloric acid secretion. Third is endocrine mechanism. It is mediated by gastrin. Gastrin increases hydrochloric acid secretion far more potently than histamine. Signals from the vagus nerve are transmitted through enteric nervous system and arrive in gastric gland and pyloric glands of the stomach. For example, vagus nerves release acetylcholine. Acetylcholine activates postganglionic fibers, which release gastrin-releasing peptide, or GRP. GRP activates G cells in the pyloric gland, which secrete gastrin. Some of the postganglionic cells release acetylcholine. Acetylcholine inhibits the release of somatostatin by delta cells. Normally, somatostatin inhibits the release of all gut hormones, including gastrin. As a result, vagus stimulation increases gastrin release and gastric secretion through two parallel mechanisms. This information is summarized in this slide. Here I want to point out two aspects. One is that entrum acidification will increase release of somatostatin, whereby it inhibits gastrin release. Second aspect is that small peptides and amino acids can directly stimulate gastrin release from G cells. This effect is not blocked by atropine. Atropine is an anticholinergic. Histamine is released from enterochromaffin-like cells, or ECL cells. Gastrin and acetylcholine stimulate histamine release from ECL cells. Proliferation of ECL cells is often associated with hypergastrinemia. It could be because of gastrin-secreting tumors. High level of gastrin cause ECL cells to proliferate. It may also occur when long-term therapy with drugs that block acid secretion. When acid level is low, gastrin level is high, that promotes ECL proliferation. This represents a parietal cell. Parietal cells have receptors for acetylcholine, histamine, and gastrin. Histamine enhances the effects of acetylcholine and gastrin. These effects can be blocked by histamine H2 receptor blocker, cimetidine. Acetylcholine can enhance effects of gastrin and histamine. These effects can be blocked by cholinesterase antagonist, atropine. Gastric secretion can be divided into three phases: cephalic phase, gastric phase, and intestinal phase. A cephalic phase occurs before food enters the stomach. It results from the sight, smell, thought, or taste of food. Stimuli are transmitted through mechanoreceptor, chemoreceptor, central pathway, through cerebral cortex, and appetite centers of the amygdala and hypothalamus. It is blocked entirely by vagotomy. After food enters the stomach, new stimuli come into play. These include increased pH, distension, presence of peptides and amino acids, calcium, alcohol, and caffeine. For example, distension excites long vagal reflexes from the stomach to the brain and back to the stomach, and local enteric reflexes. All this together stimulate the release of acetylcholine. Acetylcholine stimulates secretion of hydrochloric directly. These effects can be blocked by atropine. The effects by other stimuli can be blocked by acidification of antrum and subsequent secretion of somatostatin. Gastric phase accounts for 60% of acid response to a meal. Presence of food, especially peptides and amino acids, in the upper portion of the small intestine causes G cells in the duodenum to secrete gastrin. This phase accounts for 10% of acid response to a meal. Here is a time course of acid response to a meal. The blue line represents pH, green line represents volume of stomach, red line represents rate of acid secretion. Before the meal, pH, volume, and rate of acid secretion are all low. After the meal begins, pH, volume, and rate of secretion increase rapidly. When the meal ends, both pH and volume reach the maximum. Rate of acid secretion continues to rise. In about an hour, it also reached the maximum. Before meal, pH is low and acid secretion is suppressed. There are two mechanisms to account for this. First, acid stimulates somatostatin release from D cells. Second, acid has a direct effect on parietal cells to suppress acid secretion. During the meal, acid secretion increases because of stimulation of vagal nerves, rise of pH, and presence of peptides and amino acids in the food. Approximately 1 hour after the end of the meal, acid secretion peaks. After that, acid secretion decreases because of three mechanisms. First, within stomach, as pH falls, acid inhibits release of gastrin from G cell and acid secretion from parietal cells. Second, presence of food in the small intestine initiates a reverse enterogastric reflex that inhibits stomach secretion. Third, presence of acid fats peptides cause release of several intestinal hormones, including secretin, GIP, VIP, and somatostatin, which inhibit gastric secretion as well as gastric emptying. Mechanisms that inhibit acid secretion are summarized in this table. Please note that hormones have a direct effect on both gastrin release and acid secretion, while nervous reflex has direct effects only on acid secretion. Gastric mucosal barrier has two mechanisms to prevent back leak of proton ion. One is anatomical. It includes cell membranes and tight junctions between cells. The other one is physiological basis, which use proton pump to pump proton back to the lumen. Mucus, bicarbonate secretion, gastrin, among others, strengthen the mucosal barrier. H. pylori, aspirin, ethanol, among others, can weaken mucosal barrier and cause peptic ulcer. Here is clinical correlation. A peptic ulcer is an excoriated area of stomach or intestinal mucosa caused by the digestive actions of gastric juice or duodenal secretion. When ulcer occurs on the lining of the stomach, it is called gastric ulcer. When ulcer occurs in the duodenum, it is called the duodenal ulcer. For example, when the gastric mucosal barrier is damaged, protons back leak into the cell in exchange for sodium. This is the forerunner to gastric ulcer because decreased pH inside the cell leads to cell death. Damaged enterochromaffin-like cells leak histamine. Histamine causes vascular damage and local ischemia, which leads to a greater leak of proton and more cell death. This is a vicious cycle. Here is acid secretion in some gastrointestinal disorders. This column represents basal acid secretion. This column represents maximum acid secretion stimulated by histamine. This column represents serum gastrin level. Here we may notice two extreme cases. One is pernicious anemia, in which parietal cells are destroyed. In this case, no gastric acid secretion. Serum gastrin level is very high. The opposite condition is Zollinger-Ellison syndrome, where excess gastrin is produced. The result is high acid secretion. In between are gastric cancer, gastric ulcer, and duodenal ulcer. Decreased acid output in gastric ulcer patients is due to back leak of proton through damaged barrier. Duodenal ulcer patients often have 2 to 3 times more parietal cells than normal. As a result, there's an increase in acid secretion in duodenal ulcer patients. Increased acid lowers serum gastrin level. This information is summarized in this slide. Helicobacter pylori is found in most of the patients with peptic ulcer. H. pylori is a gram-negative bacteria with high urease activity. Urease increases production of ammonium, which help bacteria withstand acid environment. Ammonium liquefies the barrier and stimulates hydrochloride secretion. The bacteria has the capacity to burrow through the barrier. As a result, gastric acid can penetrate into the underlying epithelia and digest the gastrointestinal wall, leading to peptic ulcer. Treatment of peptic ulcer nowadays typically use 2 drugs. One is antibiotic, and the other one is acid suppressant drug. This can be one of the histamine H2 receptor blockers, such as ranitidine or cimetidine, or one of the proton pump inhibitors, such as omeprazole. Now, let's move to part 4. We will look at pancreatic secretion. The pancreas secretes digestive enzymes for digesting all the 3 major types of food. A bicarbonate solution to neutralize acidic chyme. The pancreas is a complex gland with structure similar to salivary gland. Pancreatic enzymes are secreted by acini. This is an acinus, a grape-like cluster of cells. This is an intercalated duct. Large volumes of sodium bicarbonate are secreted by ducts. Intercalated ducts, such as this one, receive secretion from acini, and these secretions will flow to interlobular ducts. The pancreas secretes proteolytic enzymes, such as trypsin, chymotrypsin. They cleave protein to small polypeptides. Carboxypeptidase cleaves polypeptides to amino acids. Pancreatic alpha amylase cleaves starches to disaccharides. Pancreatic lipase, phospholipase, cholesterol esterase cleave lipids as described in biochemistry. So here's integration with biochemistry. Here is a question. Why doesn't the pancreas digest itself? There are 2 reasons. First, pancreatic's proteolytic enzymes are stored and secreted in inactive forms. For example, trypsinogen, chymotrypsinogen, and procarboxypeptidase are inactive. They are not activated until they reach the small intestine. In the small intestine, enterokinase produced by intestinal mucosa activates trypsinogen and converts it into trypsin. Trypsin then catalyzes the activation of trypsinogen and other proteolytic enzymes. Second, acini cells also secrete trypsin inhibitor. Trypsin inhibitor prevents activation of trypsin both inside the secretory cells and in the acini and ducts of the pancreas. Although the enzymes of pancreatic juice are secreted entirely by the acini, bicarbonate and water are secreted by the epithelial cells of the ductules and ducts. Bicarbonate neutralizes acidic chyme, as shown here, creating optimal conditions for digestive enzymes. At the cellular level, there are 5 important events leading to bicarbonate secretion. First, opening of the chloride channel CFTR causes outflow of chloride into the duct lumen. An increase in chloride concentration drives activity of chloride bicarbonate exchanger. Bicarbonate moves into the lumen while chloride is reabsorbed. This is the second event. CFTR is regulated by secretin. Secretin increases cyclic AMP level in the ductular cells and open CFTR, whereby secretin increases bicarbonate secretion. Bicarbonate is derived from 2 sources. Some is generated intracellularly from carbon dioxide by carbonic anhydrase. Other bicarbonate is taken up across the basolateral membrane of the ductular epithelial cells through the sodium bicarbonate co-transporter type 1 or MBC1. This is a false event. An electrical and osmotic gradient initiated by bicarbonate drives sodium and water to cross the epithelium through the tight junctions. This information is summarized in these slides. When secretion rate is low, bicarbonate concentration is low, and chloride concentration is high. Conversely, when secretion rate increases, bicarbonate concentration increases as well. Similar to gastric secretion, pancreatic secretion also occurs in 3 phases. Before food enters the stomach, it is called the cephalic phase. After food enters the stomach, it is called gastric phase. Both cephalic and gastric phases are mediated by vagus nerve. It has a low volume because water and bicarbonate are not secreted yet. After food enters the duodenum, it is called the intestinal phase. Pancreatic secretion becomes copious, mainly because acid triggers release of secretin. 3 signals control pancreatic secretion. Presence of acid in duodenum triggers release of secretin. Secretin increases bicarbonate secretion. Presence of fatty acids and amino acid in duodenum triggers release of CCK. CCK increases enzyme secretion. Presence of acid, fatty acids, and amino acids in duodenum stimulate vagus nerve. Vagal stimulation increases enzyme secretion. So this information is summarized in this table. As you may recall, secretin is secreted by S cells in the duodenum, jejunum, and ileum. S cells secrete secretin when pH drops below 4.5. Secretin release is maximum when pH drops below 3. Pancreatic failure occurs following pancreatitis or surgical removal of pancreatic head. Without pancreatic enzymes, about 60% of fats and 30 to 40% of proteins and carbohydrates are not absorbed. Pancreatitis is inflammation of the pancreas. It could be chronic or acute. In either case, there are many causes. Here, we will use chronic pancreatitis due to cystic fibrosis as an example. Cystic fibrosis patients lack CFTR. As I described to you earlier, CFTR is a driving force for water and bicarbonate secretion. Without CFTR, watery ductal secretion decrease, which concentrate acinar secretions in ducts. Precipitation of enzyme secretion blocks ducts and can destroy the glands by autodigestion. That's why patients with cystic fibrosis often have pancreatitis. Now, let's move to part 5. We will look at secretion of bile by the liver. The liver secretes bile normally between 600 to 800 milliliters per day. Bile serves as 2 important functions. As we have covered in biochemistry, Bile is essential for fat digestion and absorption. Bile is a means to remove several waste products, especially bilirubin and excess cholesterol. Here is a structure of liver and gallbladder. Bile is secreted by the liver in two stages. The initial portion is secreted by hepatocytes into minute bile canaliculi. In the second stage, the bile flows from canaliculi to bile ducts. Finally, bile reaches the hepatic duct. A common bile duct is shown here. The bile then either empties into duodenum or is diverted through cystic duct into gallbladder. Secreting also stimulates water and bicarbonate secretion by bile ducts in a manner similar to pancreatic ducts. Gallbladder can hold up to 60 milliliters of bile. This information is summarized in this slide. Bile secretion in 12 hours is about 450 milliliters. How can gallbladder hold so much bile secretion? The answer is reabsorption in the gallbladder. Water, sodium chloride, and most other small electrolytes are continually reabsorbed, concentrating the remaining bile constituents. The most abundant organic substance in the bile are bile salts. Other significant constituents are bilirubin, cholesterol, fatty acids, and phosphatidylcholine. Now, let's move to part 6. We will look at secretion of the small intestine. The small intestine has two types of tubular glands. One is Brunner's glands. They are located between the pylorus of the stomach and papilla of fata in the duodenum. They secrete an alkaline mucus that protects mucosa from acidic chyme. Secretion is stimulated by local irritation transmitted through vagus nerve and inhibited by sympathetic stimulation. Second type of tubular glands is crypts of Lipocune. They are located in the entire surface of the small intestine. Here is a crypt of Lipocune. These are enterocytes, and these are goblet cells, and these are stem cells. In between are Paneth cells. Enterocytes mostly secrete water-like fluid. These secretions are almost pure extracellular fluid and have a slightly alkaline pH. Mechanism of secretion in crypts of Lipocune involve at least two active secretory processes, as shown in this picture. First, active secretion of chloride into the crypts through the chloride channel, CFTR. Increase cyclic AMP level in enterocytes. Increase the activity of the chloride channel. Active secretion of bicarbonate involve chloride bicarbonate exchanger. This is very similar to ductal cells in the pancreas. The secretion of both ions creates an electrical gradient which drags sodium into the lumen through tight junction. Finally, osmotic gradient moves water into the lumen as well. Finally, we will look at the secretion of the large intestine. Large intestine also contains crypts of lipocane. Therefore, it follows mechanism of secretion similar to those for small intestine. There are some differences. For example, there's no villi or digestive enzyme secreted in the large intestine. Crypts mainly secrete alkaline mucus. Mucus secretion is increased by parasympathetic stimulation,